Good morning, Philippines! I am back! Kumusta po kayo lahat? It's me again, John. Yeah, I know. Anyway, it's April 5, my day. And what time is it? It's almost 6 o'clock, 6:15 p.m. So that makes it April 6, 7 o'clock in the Philippines. Yeah, bilis ng panahon. Oh my God. And it's still gloomy outside. It's still fucking cold. Oh my God, it's springtime but still cold outside. So technically, extension siya ng winter. Yep. How's everybody? So anyway, sabi ko kanina, i-record ko na lang to and then I will upload it or broadcast it later. So bakit nga? Kasi I have an appointment tonight. So me and Ian will go somewhere else. We need to pamper ourselves. You know, sabi nila kailangan kami magpamassage. So yun. So sabi ko, mamaya pa naman yung 7:45. Anong oras pa lang? 6 o'clock. So I still have 1 hour. So I think I can finish this concept in about an hour. So we will talk about renin angiotensin mechanism. Some book, they call it renin angiotensin aldosterone system. I know it's quite mouthful, but they're all the same. Okay? So I hope this clip will help you guys with whatever qualifying examination you're planning to take. May it be the NCLEX RN or the NLE in the Philippines, or any qualifying examination in the Middle East, just like your DHA, Prometric, HAAD, name it. Well, I just hope this concept will help you if time comes that you will encounter questions pertaining to this specific, concept. Okay, give me a minute. By the way, before I start, congratulations to our new NCLEX RN passers. My God, we have 4 NCLEX RN passers for this month. April 5 pa lang ha, we have 4. Dang, that's amazing. Congratulations. I'm so happy that you made me part of your success. Not only me, but also the entire team of US Review Center, and of course, the Nurses Hub Training Center back in the Philippines. Okay, so let's talk about renin angiotensin mechanism. By the way, if you have any concerns or questions, feel free to drop a message there, and we will see. If I know the answer, I will let you know. If I don't know, I will let you know as well. See, it's a win-win situation. You learn from me, I learn from you. Okay, let's try to turn off my background music. There. Okay, so we'll talk about renin angiotensin mechanism. Hold on, let me share my screen. Sorry, wala pala. Share screen, entire screen, share, there. Okay. Okay, so we'll talk about renin angiotensin mechanism. Along the way, I will incorporate some pharmacology concept here. So we'll talk about renin. Why is it color green? Renin angiotensin. Angiotensin mechanism. Other book, it's renin angiotensin system. Doesn't matter. They're all the same. Okay. So renin angiotensin mechanism. Let's begin with renin. What is renin, Sir John? Okay. Renin is actually an enzyme. Okay. It is an enzyme. And this enzyme is actually produced by a specific cell in the kidney. So technically, the kidneys will produce an enzyme called renin. Now, what specific cell in the kidney produces renin? It's what we call juxtaglomerular cell. Okay? So, renin is actually produced by a cell called juxtaglomerular cell. And this cell, the juxtaglomerular cells, are cells that are commonly found in the linings of your afferent arteriole. Okay, afferent arteriole. Remember when you say arteriole are small arteries. Okay. And what makes this cell, we're talking about juxtaglomerular cell, what makes this cell produce or release renin? What triggers this cell? What triggers release of renin? There are actually three common factors that can trigger release of renin. Okay, so we can write it down. Triggered by, taray, no? Triggered by three factors. One, two, three. Anyway, hi, Genesis. How are you? Hello, Mami Alejandro, and hello to Krista Ang. Anyway, let's begin. First, renin is triggered by a decrease in what we called blood volume. Okay, if there is what we call hypovolemia. Why? There are a lot of factors that can cause hypovolemia, right? First, maybe related to massive blood loss or hemorrhage, okay? Or two, maybe because of excessive fluid loss, just like your severe diarrhea, okay? So either way, if there's a decreased blood volume, it can, okay, initiate or trigger release of an enzyme called renin. Okay. Second factor that can trigger release of renin is a decrease in the blood pressure. So if you're hypotensive, okay, if you're hypotensive, it can trigger release of renin. Now, why is the patient hypotensive here? Again, there's a lot of factors or conditions that can cause hypotension. Maybe relate to decreased blood volume. Remember, if you have hypovolemia, one manifestation is hypotension, right? Or maybe because the hypotension is related to shock. Okay, just like your example will be your anaphylactic shock. Remember, in this type of shock, there is peripheral vasodilation, so resulting to decreased blood pressure. Now, a patient with decreased blood volume, a patient with decreased blood pressure, okay, these two will lead to a decrease in your renal perfusion. Okay, and guess what? A decrease in the renal perfusion will lead to a decrease in your glomerular filtration rate, your GFR. Why? Because of a decrease in your renal perfusion. A decrease in the perfusion may be related to valve, okay, volume problem or pressure problem. Okay. And the third and the last factor that can trigger release of renin is if there is what we call a decrease in your sodium concentration. Are we talking about concentration in the blood? No. Okay. A decreased sodium concentration where in your distal convoluted tubule. Hold on, Sir John. Distal convoluted tubule. I heard that long time ago, but I forgot. Now, distal convoluted tubule is actually part of your nephron. Okay. And let me just draw that one. So let's say this is our kidney. Okay. We have two kidneys, the right kidney and the left kidney. Nephron is considered to the basic structural unit of the kidney. And a kidney has about 1 million of nephrons. Can you imagine that? Okay. So in the kidney, there's a nephron. Let's say, let me draw the nephron. Okay. This is a big nephron. Just for the sake of, for the purpose of discussion, okay? Okay, let's name them. Let's change the color of my pen. Let's say, let's use color blue. Okay, this is what we called your afferent arteriole. Okay, this is what we called efferent arteriole. Remember, I said efferent arteriole, afferent arteriole. Arteriole is a small artery. Okay, now you call this as the glomerulus, this part here, and you call this entire area as your Bowman's capsule. Okay, and this tube here with convolution called convoluted tubule. This type of tubule is what we call proximal convoluted tubule. This part here is the loop of Henle. Okay, if you can still remember this, this is what we call the descending loop because it descends. The loop of Henle here, it goes up. So we call this as ascending loop of Henle. This is what we call your distal convoluted tubule, the one I mentioned a while ago. Okay. And this is what we call the collecting tubule. Okay. Now, before I will talk about renin release, there are two cells I want you to remember. I mentioned the first cell, and that is what the juxtaglomerular cell. Okay, I mentioned that the juxtaglomerular cells are cells greatly makikita saan in the linings of your afferent. Okay, so you have your cells here. Okay, you have your cells here. You call these cells as your juxtaglomerular cells. Okay. Juxtaglomerular cell. Okay. And then there's another cell here in the lining of your distal convoluted tubule. Let's put it here on this side. Now, what do you call this cell? You call this cell your macula densa cell. Now, what is macula densa? Macula densa cell is a form of a chief cell. In short, it has a sensory function. Not only that, it will help regulate or maintain blood pressure, fluid balance, and electrolyte homeostasis. Okay, that's your macula densa cell. So these are two cells you need to remember. Macula densa cell in your distal convoluted tubule, and your juxtaglomerular cell in your afferent arteriole. Okay, so here's the scenario. If there is a decrease in the blood, okay, if there is a decrease, let's change my ink first. If there's a decrease in the blood pressure, okay, a decrease in the blood pressure or a decrease in the blood volume, I said that will lead to decreased renal perfusion, right? So because of a decrease in the blood pressure, low pressure is passing the afferent arteriole, that can be picked up, that can be sensed by your juxtaglomerular cell that there is decreased volume, that there is a decrease in the pressure. As a result, it triggers your juxtaglomerular cell to release an enzyme called renin. Okay, so renin is released because of a decrease in the blood volume and a decrease in the blood pressure. Simple as that. Now, as a result of decreased renal perfusion, glomerular filtration rate is actually slow or low. Okay, therefore, because of a decreased renal perfusion, the filtration rate is slow. Because of that, remember the byproduct of filtration is filtrate. That filtrate now enters the Bowman's capsule. Because of a decrease in the filtration rate, because of decrease in the perfusion, the fluid, okay, the filtrate that will pass in the tubule is slow as well. Okay, it is slow because of a decrease in the pressure, because of a decrease in what we call the volume. As a result, that fluid, the filtrate, will pass the tubule a little bit longer than expected. As a result, there will be an increase in your sodium reabsorption. More sodium is being reabsorbed to the point that when that filtrate reaches your distal convoluted tubule, the sodium concentration is very low. Why? Because prior to that, there is an increase in your sodium reabsorption. Now, what will happen? A decrease in your sodium concentration in your distal convoluted tubule can be sensed by the macula densa cell. Remember, I said a macula densa cell is a form of a chief cell. As a chief cell, it has a sensory function. Okay, therefore, because of a decrease in the sodium concentration in your distal convoluted tubule, the macula densa cell will pick it up and it will communicate to your juxtaglomerular cell. Hey, buddy. Nag-uusap sila. Hey, buddy. Hey, buddy. Okay. Hey, buddy, there is a decrease in your sodium concentration. You have to do something about it. So again, as a result, the juxtaglomerular cell will release the enzyme called renin. Okay, I hope that's clear. So these are three common factors that can trigger release of an enzyme called renin. Now, what about angiotensinogen? Okay, an angiotensinogen, on the other hand, okay, oh, sorry. An angiotensinogen, okay, an angiotensinogen is actually, okay, a substance produced by the liver, okay, in the case produced by the liver, but not in its active form, okay, not in its active form. I hope this scenario is very clear. Now let me clear my whiteboard. So here's the scenario. Okay, so we have here the kidney, okay. And then we have here renin. Okay. Then we have here, let's say this is the liver. And there you have your angiotensinogen. Angiotensinogen. Okay. Now, what did it tell you? The primary condition that will trigger activation of renin angiotensin mechanism is technically a decrease in your blood pressure or a decrease in your blood volume. Okay? Now, what did I tell you? A decrease in the blood pressure, a decrease in the blood volume will trigger release of the renin. So once renin is released, okay, renin now, okay, renin enters, okay, the bloodstream. It's in your blood, okay? What's the renin is in the bloodstream, it meets your angiotensinogen, okay? What will renin do with your angiotensinogen? Renin is an enzyme that will split, will cut angiotensinogen, okay? So it will cut angiotensinogen to become angiotensin. Okay, so one of the cut is what we call angiotensin. Angiotensin. Okay, your angiotensin 1. That's the first cut. Angiotensin 1 is still in the bloodstream. Okay, still in the bloodstream. And guess what? In the lungs, okay, in the lungs, there is an enzyme, okay? In the lungs, there is an enzyme called ACE. ACE stands for angiotensin converting enzyme. So what will it do? Just like your renin, your angiotensin converting enzyme, again, will cut angiotensin 1, converting that, okay, getting the piece called angiotensin 2. Okay? Now, here is the scenario you need to remember in your qualifying examination. And what is that? Effects of our angiotensin 2. Now, what are effects of our angiotensin 2? Let's put it on this side so that I have enough space in this area. Your angiotensin 2 has the following effects. Number 1, angiotensin 2 is a potent vasoconstrictor. Okay, it causes vasoconstriction. So what will it do is that it tells the smooth muscles in your arteries, okay, to constrict. So as the blood vessels constrict, what will happen? The blood pressure gets up. Okay, the blood pressure goes up. So it corrects hypotension. Okay, next, number 2, second effect. Your angiotensin 2, okay, your angiotensin 2, okay, stimulates your adrenal gland. What will happen once adrenal gland is stimulated? Once stimulated, adrenal gland will release a hormone, okay? It will release a hormone called aldosterone. By the way, another name of your aldosterone is your mineralocorticoid. Remember, we call it mineralocorticoid because it affects the mineral. What specific mineral? Your sodium. Remember, if you were present during my discussion of fluids and electrolytes about aldosterone, I said aldosterone is a hormone that regulates sodium release. Okay? Now, what will happen now? Once aldosterone is released, aldosterone promotes water retention. Okay, water retention. So what will happen if there is water retention? Water retention now will increase your blood volume, right? Third effect. Third effect. Once angiotensin 2 is present, guess what? Your angiotensin 2, okay, your angiotensin 2 will stimulate, okay, will trigger your pituitary gland to release ADH, okay? It stimulates PPG. What's PPG? Posterior pituitary gland. Remember, your pituitary gland is divided into two, the anterior and the posterior part. So it's your posterior part that is triggered, okay? And once triggered, the PPG or posterior pituitary gland will release a hormone called ADH. What's ADH? It's an antidiuretic hormone. So technically, what hormone is this? Okay, this is a hormone that prevents you to form large volume of urine. Okay, so it prevents formation of large volume of urine. So technically, ang gagawin niya is for water reabsorption. So take note. Aldosterone is for water retention. Antidiuretic hormone is for water reabsorption. So once water is reabsorbed, again, it increases the blood volume, correct? And the fourth, okay, effect of your angiotensin 2. Your angiotensin 2 will trigger your thirst center in your hypothalamus, okay? It stimulates thirst center. Where? In your hypothalamus. Hypothalamus. So once the thirst center is triggered, you will drink a lot of water. So if you drink a lot of water, again, it increases your blood volume, right? And guess what? When the blood volume is up, what will happen to your blood pressure? It increases your blood pressure. And when there's vasoconstriction, it will also increase the blood pressure. See the relevance of the renin-angiotensin mechanism or renin-angiotensin-aldosterone mechanism. It corrected the stimuli. Now, the initial stimuli decreased blood pressure, decreased blood volume. But because of the renin-angiotensin-aldosterone mechanism, it corrected the problem. Okay, now if blood pressure is high, it's not okay, it's not good, right? That is why there are medications given to hypertensive patients, right? Now, what medications are those? Just like your ACE inhibitors. ACE inhibitors. So it is an agent, okay? It is an agent. Example here is your captopril. Captopril. So just like your captopril, okay, your ACE inhibitor, it is an agent that inhibits this enzyme. It inhibits angiotensin converting enzyme to convert angiotensin 1 to become angiotensin 2. Because once it turns to become angiotensin 2, it is a potent vasoconstrictor. What about angiotensin 1? Your angiotensin 1 is an inactive form. It has a less vasoconstrictive property, not as potent as your angiotensin 2. Okay, so you can give ACE inhibitor, or if not, you can give receptors here that will block angiotensin 2. And what do you call that medication? You call that medication as your angiotensin receptor blockers. Okay, so anyway, what I want to focus here is your captopril. So most of your ACE inhibitors are agents that will end, okay, with pril, just like captopril, that's your lisinopril. Okay, now don't forget this in your examination. The most common side effect of your captopril, here's your technique, captopril, cough, cough. Cough is a common side effect of your ACE inhibitor. But if you stop taking ACE inhibitor, that side effect cough will also disappear. Now, another thing, if your patient is having hyperkalemia, and what is that? An increase in your blood potassium level. We discourage patients with hyperkalemia to take ACE inhibitor drugs. Why? The more it increases your blood potassium level. So don't forget that. Patient with hyperkalemia or a blood potassium is greater than 5, okay, we discourage you taking ACE inhibitors because, again, Okay, it will increase. The more it increases your blood potassium level. Not only ACE inhibitors, avoid salt substitutes because salt substitutes contain a lot of potassium. So again, this is what we call your renin angiotensin mechanism. So this mechanism is important, especially if you have hypo. Hold on. Let me turn this thing off. Okay, yun nga. So this renin angiotensin mechanism is so essential, especially if you have hypotension and if you have hypovolemia, because this mechanism will correct hypotension and will correct hypovolemia. So I hope you learned something, guys. Anyway, what do we have here? You have some comments. Here, hello to April Bulan, hello to Kate McRohan, hello to Carol Latouche. That's a nice family name. Hello to Joey Meadows, Mommy Mai, and Joya Dizon. I hope you learned something. If you reach this part, thank you so much. It's almost 7 o'clock and I have an appointment at 7:45. Thank you so much, guys. I hope you learned something. I'll see you again very soon. Okay. God bless. Keep safe. Bye.